your pediatric patient is pale, shaking, and their blood glucose is, well, it's crashing fast.
Yeah, that is an absolute nightmare scenario.
Right, so you need a fast-acting carb immediately. But instead of grabbing a packet of pure sugar or, I don't know, a hard candy, you reach for a glass of whole milk. Why?
It sounds totally counterintuitive, right?
It really does. And welcome to today's deep dive. We are talking directly to you, the nursing student, who is staring down the barrel of the ATI RN Pediatric Nursing Proctored exam.
You've got this.
You already know that the sheer volume of information on pediatric endocrine disorders is just staggering. It's so easy to get lost in, like, a sea of lab values and medication protocols.
Oh, absolutely. The flashcard memorization trap is real.
Exactly. So our mission today is to pull you out of that trap and anchor these concepts in absolute clinical logic. We're looking specifically at endocrine disorders, chapters 33 and 34 from your review module.
Because honestly, when you understand the physiological mechanisms, like the actual why behind a clinical presentation, you just start guessing on those multiple choice questions.
The right answer just becomes the only logical outcome.
Exactly. You can visualize the patient, you understand the pathophysiology, and the nursing interventions just naturally fall right into place.
That is the ultimate goal. So today, we are mastering pediatric endocrine by focusing heavily on this idea of metabolic balance.
I love that framing.
Yeah, we're going to deconstruct how a child's body regulates its daily energy fuel, which is blood glucose, and what it looks like when that system spirals into a life-threatening crisis.
And then we'll seamlessly shift into how the body governs its long-term architectural blueprint, right? Which brings us to growth hormone.
It's a really phenomenal contrast. I mean, daily fuel management versus long-term structural development.
But both require incredibly precise hormonal regulation. And, both present very distinct challenges in a pediatric population.
So true. Let's start with that daily balancing act. Diabetes mellitus. For the ATI exam, distinguishing the etiology and the clinical manifestations of the two primary types is foundational.
Right. You have to know the difference, Cole.
So type 1 is your absolute insulin deficiency. The beta cells in the pancreas are destroyed, often due to, well, a genetic predisposition coupled with a trigger like a virus or a toxin.
The insulin factory is basically just shut down.
Yeah, shut down completely. And then you have type 2, which unfortunately we are seeing at significantly higher rates in pediatric populations now.
We really are. And this is a story of insulin resistance. It's driven by risk factors like physical inactivity, hypertension, obesity, and elevated triglycerides.
Oh, quick note on those triglycerides, you want to keep an eye out for levels over 250 milligrams per deciliter on an exam.
Great point. So with type 2, the pancreas is still producing insulin, but the cells are essentially ignoring the signal.
Now, here is a fascinating clinical indicator for type 2 in kids that feels like a guaranteed exam question.
Oh, I know where you're going with this.
It's not just about BMI or blood pressure. One of the stealthiest early indicators you might see is recurrent vaginal yeast infections.
It's such a brilliant diagnostic clue. I mean, think about it. Excess glucose in the bloodstream eventually spills over into the urine and tissues, right?
Right.
So you are essentially creating a highly glycemic, sugar-rich environment in the genitourinary tract.
And yeast just loves sugar.
Exactly. The normal flora gets completely overwhelmed, and the yeast thrives on that excess sugar. So, if a young patient presents with recurrent candidiasis, your index of suspicion for type 2 diabetes should immediately go up.
That is such a good takeaway. Now let's look at the numbers and the extremes. Hypoglycemia is a blood glucose under 60.
Under 60, yeah.
And hyperglycemia is typically anything over 250 today. But on an exam, they won't always just hand you the lab value.
No, of course not. They're going to give you a patient presentation and ask you what's happening.
Right. So this is where I want to get into the physiology, because the physical manifestations are complete opposites.
They really are.
Yeah.
So with hypoglycemia under 60, the child presents with hunger, irritability, slurred speech. But clinically, their skin becomes noticeably pale, cool, and diaphoretic.
Like they are just sweating profusely.
Yes.
But contrast that with hyperglycemia over 250. They present with intense thirst, early polyuria that can, progress to oliguria, and Kussmaul respirations.
And their skin is completely different.
It is warm, extremely dry, and flushed. So when I was first learning this, I just tried to memorize the rhyme, cool and clammy, give 'em candy.
We all did.
Right. But I want to know the engine mechanics here. What is the actual physiological driver behind that sudden temperature and moisture shift?
Okay, let's break it down. Hypoglycemia is, at its core, a neurological emergency. The brain relies almost exclusively on glucose.
So when it doesn't get it, it panics.
Exactly. When levels drop under 60, the brain panics and triggers a massive systemic fight-or-flight response. It dumps huge amounts of epinephrine adrenaline straight into the bloodstream.
Okay, adrenaline.
And adrenaline causes peripheral vasoconstriction. It clamps down the blood vessels in the skin to shunt blood to the core to protect the vital organs.
Ah, and that makes the patient look pale and feel cool to the touch.
You got it. And simultaneously, that adrenaline surge triggers the sweat glands. So that cool diaphoretic presentation isn't actually a direct result of low sugar.
Wait, really?
No, it is the physiological aftermath of a massive adrenaline dump.
Wow, that reframes it entirely. It's a pure sympathetic nervous system panic attack.
Okay, so what about the warm, flushed, dry skin in hyperglycemia?
That is a story of profound volume loss. When blood glucose climbs over 250, the blood becomes hyperosmolar. It is essentially turning into syrup.
Yikes. Syrup blood.
Right. So the kidneys attempt to compensate for this by filtering all that excess glucose into the urine. But because glucose is an osmotic diuretic, it drags water right along with it.
So the child enters a state of massive polyuria, just urinating out huge volumes of fluid.
Exactly. They become profoundly systemically dehydrated. Without adequate fluid volume, the body literally doesn't have the moisture left to produce sweat.
Hence the dry skin.
And it flushes and gets warm because the body is losing its ability to effectively regulate its core temperature through evaporation. Adrenaline panic versus osmotic dehydration. If you just anchor the symptoms to those two mechanisms, you will never get a hypo or hyperglycemia presentation wrong on a test.
And that physiological understanding bridges perfectly into how we manage this at home, day in and day out.
Let's get into those everyday parameters. For diagnostics, an 8-hour fasting blood glucose greater than or equal to 126 is diagnostic.
Right.
An oral glucose tolerance test greater than or equal to 200 is diagnostic. Now, the HbA1c targets are interesting because they are actually staggered by age.
Yeah, this is a very pediatric-specific concept.
So for children under 6, the target is less than 8.5%. For ages 6 to 12, it tightens to less than 8%. And for 12 and up, it's less than 7.5%.
Those staggered targets reflect the reality of pediatric development. You simply cannot maintain a tight 7% A1C on a toddler.
Because they're toddlers.
Exactly. Their eating habits are erratic, their activity levels fluctuate wildly, and, they can't always communicate when they feel low. Pushing their A1C too low risks a fatal hypoglycemic event.
So we give them a slightly higher target, the 8.5%, just for safety.
Yes. As they grow and gain metabolic stability and communication skills, we tighten that leash to prevent long-term microvascular damage.
That clinical context helps so much. Now, when it comes to nutrition, the gold standard for exams is carbohydrate counting. The rule is 15 grams of carbohydrates equals 1 carbohydrate exchange.
Which is super important for dosing insulin.
Right. Which brings me back to my opening scenario about treating a hypoglycemic crash. The protocol says we need 10 to 15 grams of simple carbs, like 1 tablespoon of sugar, 3 to 6 ounces of orange juice, or 8 ounces of milk.
Yep. The classic interventions.
But on the surface, if a kid is shaking, sweating, and dropping below 60, orange juice makes total sense. It's liquid sugar. Why is milk an acceptable and sometimes preferred intervention here?
It really comes down to sustained metabolic recovery. Orange juice or like a tablespoon of straight sugar will absolutely spike the blood glucose fast.
It's the immediate rescue.
Right. But because it is pure, unadulterated, simple sugar, it burns off rapidly. If you treat a severe low with just juice, that child's blood sugar is highly likely to plummet right back into a dangerous trough maybe 20 minutes later.
A rebound crash.
Exactly. Milk is chemically brilliant for this. 8 ounces of whole milk contains lactose, which is a simple carbohydrate that provides a fast enough glucose spike to pull them out of the danger zone.
Okay, so it gets them out of the red.
But milk also contains proteins and fats. Those macronutrients significantly slow down gastric emptying and the subsequent absorption of the remaining sugars.
Oh, wow.
So milk gives you the immediate rescue, but it acts as a physiological bridge, sustaining that blood glucose level over time so the child stabilizes.
It's the immediate rescue plus the safety net. That is so cool. Now, just to be thorough, if that patient is unconscious or unable to swallow, we bypass oral routes entirely to prevent aspiration, right?
Absolutely. Do not put liquid in an unconscious person's mouth.
The immediate intervention there is administering glucagon subcutaneously or intramuscularly.
Always prioritize the airway. An unconscious hypoglycemic patient needs injectable glucagon, period.
Let's pivot to the sick day rules. This is a massive area for the ATI. When a diabetic pediatric patient gets a cold, the flu, or gastroenteritis, home management becomes highly specialized.
It changes the whole game.
You have to monitor their blood glucose and urinary ketones every 3 hours. But here is the piece that trips up so many students. The protocol explicitly dictates that you do not stop taking anti-diabetic agents.
Which feels wrong to a lot of parents.
I mean, I look at the sick day protocol and it feels like a trap. A kid is actively vomiting, they are NPO at home, and I'm supposed to give them their standard insulin dose. That feels like a fast track to severe hypoglycemia.
It is the most common and, frankly, the most dangerous misconception parents have. They think, my child hasn't eaten a thing all day. If I give them insulin, they will bottom out.
Right, which makes logical sense until you look deeper.
Exactly. Illness, even just the simple viral infection, is a major physiological stressor. When the body is under stress, the hypothalamic pituitary adrenal axis kicks into overdrive.
The body dumps massive amounts of cortisol and epinephrine.
Yes. Cortisol specifically stimulates gluconeogenesis in the liver, drastically driving blood glucose levels UP to give the immune system the energy to fight the infection.
So the stress of the illness actually causes a hyperglycemic spike, independent of any food intake.
Exactly. Even if that child hasn't eaten a single cracker, their blood sugar could be sitting at 300 purely from the cortisol response.
Wow.
So if you stop their insulin, they will rapidly slide into ketoacidosis. You have to continue the insulin, push sugar-free fluids to maintain hydration and flush ketones, and call the provider if the blood glucose stays above 240.
Or if they show positive urinary ketones, or if they vomit more than once.
Right. Those are your red flags to call the doctor.
That makes absolute sense. A quick note on insulin administration techniques before we move on. You must rotate injection sites, but the ATI requires a specific pattern.
Yeah, pay attention to this one.
You get 4 to 6 injections in one specific area, keeping them about 1 inch apart, before transitioning to a completely different anatomical site. This prevents lipohypertrophy.
Crucial for tissue health.
And crucially, never mix insulin glargine with other insulins in the same syringe due to chemical incompatibility.
Right, because glargine has an acidic pH. It's designed to form these microprecipitates in the subcutaneous tissue for a very slow 24-hour release.
So if you mix it
with a neutral regular insulin, you just destroy the release mechanism of both drugs. It's a huge medication error.
Good to know. Which brings us to the scenario where the daily management fails entirely. The diabetic ketoacidosis, or DKA emergency.
This is a critical care situation.
We're shifting from routine outpatient management to a life-threatening crisis.
DKA is a very complex cascade. The clinical profile you absolutely need to recognize includes hyperglycemia greater than 330, a profoundly acidic blood pH of less than 7.30, a bicarbonate level less than 15, and heavy ketones in both the blood and urine.
Let's trace that cascade for a second. Because there is no insulin, the cells are literally starving in a sea of glucose. They just can't access the sugar.
Right, they're locked out.
So the body panics and starts breaking down peripheral fat stores for energy. That lipolysis produces massive amounts of ketone bodies, which are highly acidic.
And those ketones flood the bloodstream, tanking the pH and throwing the child into a severe metabolic acidosis.
And that metabolic acidosis is why you see Kussmaul respirations.
Exactly. The child is taking deep, rapid breaths, not because they are short of breath, but because their respiratory system is desperately trying to compensate by blowing off volatile acids in the form of carbon dioxide.
It's the body's way of exhaling the acid. The nursing actions for DKA are intense and highly sequential. First, you admit them to the PICU. You establish venous access immediately.
You start normal saline to correct that profound dehydration we talked about earlier.
And then the specific treatment protocol involves administering regular insulin continuously via an IV infusion at 0.1 unit per kilogram per hour.
But here is the physiological trap that the ATI tests relentlessly.
The potassium shift.
Yes, it is the most critical safety concept in DKA management.
Let me set up a metaphor for this. Treating DKA is like putting out a massive house fire with an industrial fire hose.
Okay, I like where this is going.
You absolutely have to put out the flames, which is the blood glucose sitting at 400 or 500. So you turn on the high pressure hose, which is the continuous IV insulin drip.
Right.
But in the process of extinguishing the fire, you cause severe collateral water damage to the foundation. In DKA, that collateral damage is a sudden lethal drop in serum potassium.
It drops so fast.
So why exactly does insulin, a hormone designed to manage glucose, completely tank the patient's potassium levels?
It is all about the cellular doorways. Insulin is the key that unlocks the cell membrane to let glucose inside. But it doesn't just passively open a door. It actively stimulates the sodium-potassium ATPase pump on the cell membrane.
Okay.
This pump physically grabs potassium from the extracellular fluid, the bloodstream, and forces it intracellularly alongside the glucose.
So the potassium isn't actually leaving the body, it's just being aggressively hidden inside the cells.
Correct. When a patient arrives in DKA, their initial serum potassium might actually look normal or even high because the acidosis pulls potassium out of the cells.
But the second you start that IV insulin infusion,
You activate billions of sodium-potassium pumps simultaneously. The potassium shifts out of the blood and into the cells so rapidly that the patient develops profound sudden hypokalemia.
and hypokalemia triggers lethal cardiac arrhythmias.
Exactly, which dictates your exact order of nursing interventions. You never start the insulin drip until you have placed the child on a continuous cardiac monitor. You have to be able to see those T waves invert in real time.
So cardiac monitor goes on first. Then we start the fluids. But there is another strict rule before we fix the potassium. We know the potassium is going to drop, so we need to add potassium to the IV fluids.
Right.
But we cannot administer IV potassium until we have explicitly verified adequate urinary output. Why is that?
Because if the severe dehydration of DKA has caused an acute kidney injury, the kidneys cannot excrete excess potassium.
Oh, man.
Yeah, if you hang an IV bag with potassium and the kidneys aren't working, that potassium will pool in the bloodstream, leading to hyperkalemia, which, will cause cardiac arrest just as quickly as hypokalemia.
So you have to see urine in the catheter bag or a wet diaper to prove the kidneys are filtering before you administer a single milliequivalent of potassium.
That is the rule.
That sequence is unforgettable when you understand the mechanics. Cardiac monitor on, fluids running. Verify a wet diaper. Start the insulin drip. Add the potassium. That is the DKA survival protocol.
It really is a masterclass in prioritizing physiological needs.
We've spent this entire time focused on how the body regulates its daily metabolic fuel. But what happens when the issue isn't about the daily energy, but the actual architectural blueprint of the body?
That's a huge shift.
It is. Let's zoom out and look at Chapter 34, Growth Hormone Deficiency.
So we are moving from the pancreas up to the pituitary gland. Growth hormone, or somatotropin, dictates the structural development of bone, muscle, and tissue.
And when the pituitary fails to secrete adequate amounts, the entire skeletal framework stalls.
Exactly.
Now, while risk factors can include pituitary tumors or severe brain trauma, most of these cases are idiopathic, meaning the origin is completely unknown. The child simply stops growing at the expected rate.
But the clinical presentation is very specific.
Obviously, you see short stature, but the key diagnostic phrase to look out for in your exam is short stature with proportional height and weight. They will also have delayed epiphyseal closure, delayed dentition, and delayed sexual development.
That word proportional is doing massive heavy lifting for your differential diagnosis.
Let's hone in on that.
Yeah.
When you hear short stature, you might immediately picture a skeletal dysplasia, like achondroplasia. But in those conditions, the limbs are disproportionately short compared to an average-sized torso.
Right.
Why is the proportional distinction a massive flashing neon sign for an endocrine issue?
Because it separates a localized structural defect from a systemic communication failure. In skeletal dysplasias, the cartilage in the long bones of the arms and legs has a genetic defect. It simply cannot convert to bone correctly.
But the rest of the body grows normally.
Yes. Growth hormone, however, is a systemic messenger. It circulates in the blood and tells absolutely every cell in the body to divide and grow.
So if you are missing that master signal,
The entire body scales down equally. The torso, the limbs, the facial structures, everything is perfectly proportionate, just significantly smaller than expected for their chronological age.
everything is just on a smaller scale. Another vital clinical finding to remember, these children often exhibit increased insulin sensitivity. Keep that in your back pocket.
Yes, definitely highlight that one.
Now, how do we definitively prove this is a pituitary issue? We start by drawing plasma IGF-1 and IGF-BP3 levels. If those are abnormally low, we bring out the heavy artillery, the GH stimulation test.
And the nursing protocols for this test are incredibly rigid for a reason.
The procedure dictates that you draw a baseline blood sample between 0,600 and 0,800. Then, you administer a pharmacological trigger, often arginine or clonidine, to artificially force the pituitary to release growth hormone.
Right, to see if it even can.
Exactly. You then draw blood samples every 30 minutes for a 3-hour period to plot the pituitary's exact response. But the crucial nursing intervention here is that the child must be strictly fasting and must severely limit their physical activity for 10 to 12 hours prior to the test.
It is strict.
Oh, why is that baseline so sensitive?
Well, growth hormone is not released in a steady, continuous stream. It is pulsatile, and it is highly reactive to physiological stress.
Oh, like cortisol.
Exactly. A
Yeah.
heavy meal, a spike in blood sugar, or even just walking briskly down the hallway to the lab can naturally trigger or suppress a burst of somatotropin.
So if the child eats breakfast or runs around the waiting room, you ruin the baseline.
You absolutely ruin it. You need to capture the pituitary gland in an absolute state of physiological silence so you can accurately measure its response to your specific chemical trigger.
That completely explains the strict resting requirement. Once we confirm the diagnosis, treatment relies on somatropin synthetic growth hormone.
And the nursing care involves meticulously plotting their growth trajectory.
Right, children under 3 are measured every 6 months, over 3 every year. And note this, their bone age, evaluated via X-ray, usually matches their height age, not their actual chronological age.
You also have to navigate the psychosocial impact. It's crucial to reassure anxious parents that while physical growth and sexual maturation are delayed, this deficiency does not inherently cause any cognitive or intellectual delays.
The somatropin is administered via subcutaneous injection 6 to 7 days a week, but treatment has a very defined finish line. You stop the injections when the child's growth velocity slows to less than 1 inch per year.
And when X-rays confirm their bone age has reached 14 in girls and 16 in boys,
Why those specific ages?
that age correlates with the fusion of the epiphyseal plates. Once the cartilage in those growth plates calcifies and fuses into solid bone, no amount of synthetic hormone will increase their vertical height. The window for growth is permanently closed.
Taking subcutaneous injections almost every day for decades sounds grueling. I can imagine families experiencing severe treatment fatigue and wanting to stop early, especially once the child looks tall enough.
It happens more often than you'd think.
But there are serious complications to untreated or prematurely abandoned therapy. Beyond disrupted vertical growth and delayed sexual development, the text specifically lists premature aging later in life.
Which sounds terrifying.
It does. How does stopping growth hormone at age 10 lead to premature aging at age 40?
That is a phenomenal question. We call it growth hormone, but in adulthood, its primary function shifts to cellular maintenance and metabolic regulation.
So it's not just for getting taller.
Not at all. Somatropin is deeply involved in maintaining bone mineral density, regulating lipid metabolism, and driving cellular turnover in skin and muscle tissue. So, if you abandon treatment while the body is still developing its baseline infrastructure, the patient loses that vital signal for cellular renewal.
The maintenance signal is gone.
Right. Their tissues begin to degrade, their cardiovascular risk skyrockets due to altered lipid profiles, and their bone density plummets. They exhibit the physiological markers of aging decades earlier than they should.
It's not just about reaching an acceptable height for prom. It's about building a sustainable cellular infrastructure for their entire adult life. That completely changes how you educate a family on compliance.
It absolutely does. You're treating the 40-year-old just as much as the 10-year-old.
Okay, let's distill the vital high-yield takeaways for you, the listener, before you walk into that exam. From the diabetes chapter, nail down the extreme thresholds. Hypo is under 60, hyper is over 250.
Know them cold.
Understand the adrenergic panic that causes pale, sweaty skin and hypoglycemia versus the profound osmotic diuresis causing flushed, dry skin and hyperglycemia.
Remember the milk bridge for sustained glucose recovery?
Burn the sick day rule into your memory. Never withhold insulin during an infection because cortisol drives glucose up. And in a DKA crisis, fear the potassium shift.
Cardiac monitor on, verify a wet diaper, then give your insulin and potassium.
From the growth hormone chapter, look for the proportional short stature. Know the strict fasting and resting protocols to capture a true baseline in the GH stimulation test.
And remember the stopping criteria for somatropin: fusion of the epiphyseal plates, a growth rate of less than 1 inch per year, or a bone age of 14 for girls and 16 for boys.
If you master those physiological mechanisms, the ATI questions become incredibly transparent.
You won't even need to memorize the answers.
But before we sign off, I want to leave you with one final clinical scenario to test your new mastery of metabolic balance. We noted earlier that children with growth hormone deficiency often have increased insulin sensitivity.
We did.
And the guidelines state that somatropin must be used very cautiously in children receiving insulin.
It is a brilliant clinical intersection.
Imagine stepping into the room of a pediatric patient who has been diagnosed with both type 1 diabetes and growth hormone deficiency. Their body is already exquisitely sensitive to their daily insulin doses. What happens the week you initiate their new daily somatropin injections?
It's going to be chaos.
Right. As that synthetic growth hormone floods their system, waking up their cellular metabolism, driving lipolysis, and triggering rapid structural growth, it is going to fundamentally alter their insulin resistance.
Because the somatropin acts as a counter-regulatory hormone to insulin.
Exactly. How wildly will their daily insulin requirements fluctuate as they suddenly enter a massive growth spurt? Managing the blood glucose of a child actively receiving somatropin is the ultimate test of nursing vigilance.
It really is the ultimate test.
Think through how you would monitor and adjust their care plan. Keep pulling on those threads, keep asking why, and you're going to absolutely crush this exam. Good luck out there.